Okay, welcome to the Deep Dive, your shortcut to getting truly well-informed on a complex topic, tailored just for you based on the sources you've shared. Today, we're embarking on a deep dive into some fascinating material from the world of oncology, specifically focusing on the lower gastrointestinal tract, pulling insights from Chapter 81 and the beginning of Chapter 82 of the text you've provided.
That's right. Our goal in this deep dive is to go beyond just a surface-level understanding. We're aiming for mastery here, like an elite professional would approach this material, really understanding the nuances, the surprising facts, and the most important clinical implications discussed in these pages.
Absolutely. We'll cover a range of topics presented in the sources, starting with some less common but critically important small bowel tumors. Then, we'll dedicate a significant amount of time to colorectal cancer, a major disease, where the text reveals some really striking trends and lays out the landscape of risk factors, diagnosis, staging, and the latest treatment approaches.
Yeah, there's a lot to unpack there.
We'll also touch on anal cancers, which have seen remarkable shifts in management, before concluding with what the source tells us about the initial understanding of liver cancer risk factors. Get ready to unpack some key information and maybe rethink a few things you thought you knew.
We're pulling all of this directly from the pages, highlighting what's most important for you to grasp for a comprehensive understanding.
Let's jump right in, starting with those small bowel tumors. Now, when most people think about GI cancers, they usually picture the stomach or the colon.
And there's a reason for that. The sources are clear that cancers of the small bowel are relatively rare compared to cancers of the large intestine or stomach. Despite the small intestine being the longest part of the digestive tract, it's an uncommon site for tumors.
The material you've shared categorizes these into two main groups we need to understand: carcinoid tumors, which fall under the umbrella of neuroendocrine tumors, or NETs, and then benign neoplasms.
Let's first focus on the small bowel carcinoid tumors, the NETs. While still uncommon globally, the text provides some interesting statistics. In the United States, the estimated incidence is around 9 cases per million people.
Okay, here's where it gets really interesting. The sources point out that even though they're rare, the incidence has actually increased. And what's puzzling is that well-known genetic predisposition syndromes like MEN1 and NF1 are considered unlikely to be the cause of this rise.
Exactly. This presents a bit of a puzzle. If the genetic factors we commonly associate with certain neuroendocrine tumors aren't driving this increase, what could be? It suggests we might need to look elsewhere, perhaps at environmental factors, changes in diet, or, even better detection methods, though the text doesn't definitively state the reasons.
The material also notes a racial disparity. These tumors are reported as more common in African Americans compared to white individuals. Another piece of information that points to potential underlying differences in risk factors or detection patterns.
When we look at where these small bowel nets occur, the location matters. The text specifies the frequency by anatomic site. The ileum, the final section of the small intestine, is the most common location, accounting for roughly 49% of cases.
Almost half.
Yeah. The duodenum comes next, followed by the jejunum.
Understanding the pathology is key, and the sources explain how these are graded and classified. Grading, which is a measure of how quickly the tumor cells are dividing, is based on assessing the mitotic rate, essentially, counting the number of cells undergoing division and Elidor, using Chi-67 immunohistochemistry.
Right, Chi-67 is a protein expressed in actively dividing cells, so its level gives an indication of sort of proliferative activity.
And the histological differentiation, meaning how closely the tumor cells resemble normal cells, uses the same criteria applied to gastric carcinoid tumors. So there's a standardized system.
Exactly. It connects them to other nets in the GI tract.
Now, how do these tumors typically make themselves known? The symptoms can be quite subtle.
They often are. The text notes that symptoms can be vague, maybe just some non-specific abdominal discomfort. That is, unless the tumor grows large enough to obstruct the narrow lumen of the small bowel, in which case patients would experience symptoms of small bowel obstruction, like cramping abdominal pain, nausea, and vomiting.
And the text brings up carcinoid syndrome, a classic association many people might have heard of. But there's a crucial detail here that clarifies when this syndrome typically occurs.
Yes, and this is where understanding the physiology is key. The sources state that carcinoid syndrome is usually found in patients with established hepatic metastasis, liver mets.
Okay, why is that?
Well, it's because of the liver's incredible efficiency. Normally, hormones like serotonin produced by a small bowel net are released into the portal venous system and travel directly to the liver. The liver's enzymes effectively inactivate most of the serotonin on the first pass.
So the liver acts as a filter.
Precisely. For enough active hormone to reach the systemic circulation and cause symptoms like flushing, diarrhea, bronchospasm, or even heart valve problems, carcinoid heart disease, it typically has to bypass that hepatic filter. The most common way this happens is when the tumor has spread to the liver.
Ah, check.
The liver metastases can release hormones directly into the hepatic veins, which drain into the systemic circulation, or in cases of massive liver involvement, the liver's filtering capacity is just overwhelmed. So understanding this, the insight is that if a patient presents with classic carcinoid syndrome symptoms from a small bowel net, you should strongly suspect the presence of liver metastases. The syndrome typically doesn't occur without them.
A critical piece of clinical knowledge from the text. It flips the association slightly. Syndrome implies liver mets, not just a primary small bowel tumor.
The sources also mention that nets originating in the duodenum can sometimes be gastrinomas, which secrete gastrin and can cause Zollinger-Ellison syndrome with severe peptic ulcer disease, a different set of functional effects.
So considering these often vague initial symptoms and the link between severe symptoms like carcinoid syndrome and liver involvement, how are these tumors actually evaluated and diagnosed?
Evaluation involves imaging and endoscopy. High-quality cross-sectional imaging, like a CT or MRI scan of the abdomen and pelvis, are standard tools to locate the primary tumor and assess for spread.
And then there's site-specific evaluation. For duodenal tumors, higher up.
Right. For those, upper endoscopy combined with endoscopic ultrasound, or EUS, which uses sound waves from a probe during endoscopy to get detailed images of the bowel wall, is used. For tumors further down in the jejunum or ileum, a colonoscopy might reach the distal small bowel, or specialized small bowel imaging like CT enterography is employed.
CT enterography, that specifically highlights the small bowel.
Yes, it uses IV contrast and precise timing. Here's a practical note from the text that's important. If you suspect a small bowel obstruction, you should avoid capsule endoscopy.
The camera pill. Why avoid that?
Well, if there's a significant narrowing or obstruction caused by a tumor, there's a real risk the capsule could get stuck. That could potentially worsen the obstruction or even require surgery to get it out. So it's contraindicated in that setting.
Got it. Beyond just finding the primary tumor, assessing the extent of the disease is crucial for NETs because they often spread.
Yes, and for this, somatostatin analog imaging is key. The text mentions using gallium-68 dotatate scans. Many NETs express somatostatin receptors on their surface, and this specialized PET-C scan uses a radioactive tracer that binds to these receptors.
So it lights up where the tumor cells are.
Exactly. It's incredibly sensitive for finding primary tumors and metastases anywhere in the body that express these receptors. This scan is vital for accurately staging the disease and identifying patients who are candidates for therapies that target these very same somatostatin receptors.
The sources also highlight that small bowel nets have their own specific staging system. The AJCC 8th edition TNM stage classification for small bowel nets is distinct from adenocarcinomas.
Right, acknowledging their unique biology and patterns of spread. You don't just lump these in with other GI cancers when it comes to staging.
When we look at how patients with small bowel nets typically present at diagnosis and how they are initially managed, the text provides some useful proportions. A significant number, about 40%, present with locoregional disease, meaning spread to nearby lymph nodes.
And a notable proportion, 10–15%, already have distant metastatic disease when they're first diagnosed, most commonly to the liver, as we discussed.
The primary approach to initial management, particularly when the disease appears localized, is surgical resection with curative intent. The goal is to remove the entire tumor.
However, this surgery can be quite involved. The text notes that for patients with extensive lymph node involvement at the root of the mesentery, where major blood vessels are located, vascular reconstruction might even be required. Complex operations.
And here's another crucial detail from the text about surgery. Small bowel nets can be multiple.
Right. In 15–30% of patients, there's more than one tumor in the small bowel. Because of this, the entire length of the small bowel must be carefully examined during the operation, not just the obvious tumor, to ensure all primary sites are found and removed.
And for patients whose tumors are functional, meaning they produce hormones, there's a vital step required before surgery and anesthesia.
Absolutely critical. Somatostatin analog therapy, such as administering octreotide, must be given preoperatively. Anesthesia and surgical manipulation can trigger a massive release of hormones from the tumor, leading to a life-threatening event called a carcinoid crisis.
Wow.
Pre-treating with the somatostatin analog, which inhibits hormone release, is essential to prevent this. This is a key clinical management pearl from the text.
What about managing metastatic disease, particularly the liver metastases we discussed earlier?
For managing hepatic metastasis, palliative options aim to control symptoms or tumor growth. These include surgical resection of the liver mets or regional therapies like ablation destroying tumors with heat or cold, or hepatic artery embolization, which blocks blood supply to the tumors.
And these can help with symptoms from functional tumors.
Yes, they can be particularly effective for palliating symptoms by reducing the hormone-producing tumor burden in the liver.
And those somatostatin receptor targeted therapies you mentioned earlier.
Yes, agents like octreotide or lamreotide can palliate carcinoid syndrome in most patients whose scans showed somatostatin receptor avid disease. There's also peptide-directed radiation therapy using lutetium-177.
Targeted radiation.
Exactly. It delivers targeted radiation directly to tumor cells expressing somatostatin receptors, offering another option for palliation in selected patients.
For widespread metastatic disease that requires systemic therapy, the text mentions everolimus.
An mTOR kinase inhibitor. It has shown modest activity in controlling metastatic small bowel carcinoid tumors, providing another tool in the oncologist's armamentarium.
So that gives us a solid overview of the carcinoid net side. Now let's quickly cover the other category of small bowel tumors mentioned, benign neoplasms.
Like the malignant ones, benign small bowel neoplasms are also rare.
The text includes precursor lesions in this category, such as adenomas and hamartomas. Benign initially, but they can potentially develop into cancers.
They can, especially when they are linked to inherited syndromes. This is where the connection to hereditary conditions comes in. These benign lesions can be driven by inherited susceptibility genes associated with syndromes like familial adenomatous, polyposis, FAP, Lynch syndrome.
Which we'll discuss more with CRC.
Right. And Peutz-Jeghers syndrome, among others. The text also lists other types like lipomas, fatty tumors, leiomyomas, smooth muscle tumors, neurofibromas, and benign lymphoid nodular hyperplasia.
How do these benign lesions typically present?
Usually, if they aren't part of a known inherited syndrome where patients are undergoing surveillance, they are asymptomatic. They might be discovered incidentally during imaging, like a CT scan done for another reason.
But they can cause symptoms.
They can if they bleed or get large enough to cause mechanical issues. The text mentions occult or ovate bleeding, or intussusception, where one segment of the intestine telescopes into another, causing obstruction and pain. If symptoms like these occur, they prompt a workup, often involving specialized endoscopy like double balloon or push enteroscopy.
And treatment for these benign lesions.
The general approach, especially if they are symptomatic or found during surveillance in high-risk patients, is endoscopic removal if it's technically feasible. For instance, in Peutz-Jeghers syndrome, removing the polyps is important to reduce the risk of intussusception. Mucosectomy might be used to treat bleeding hemangiomas.
So even the benign lesions in the small bowel aren't always simple findings. They can be associated with serious hereditary conditions or cause complications. That gives us a good foundation on the less common end of lower GI tumors.
It highlights that even rare cancers and benign lesions have specific characteristics, evaluation methods, and management strategies that are important for a complete understanding.
All right, let's shift our focus now to a much more prevalent and significant area, colorectal cancer. This will be a much deeper dive based on the material you've shared.
Indeed. Colorectal cancer, or CRC, is a major public health concern. The sources state its significance quite starkly. It's the second leading cause of cancer death in the United States, following only lung cancer.
And the numbers from the text reflecting 2021 data are sobering. 149,500 new cases estimated and 52,980 deaths.
Now, the text presents a really interesting and concerning paradox when we look at incidence trends over the past few decades. There's actually good news for one age group.
Okay.
The incidence rate of CRC has decreased significantly over the past 30 years in individuals 50 years or older.
And the sources attribute this positive trend largely to enhanced and more compliant screening practices like colonoscopy in this older population.
The mortality trend mirrors this. Death rates from CRC in this age group have also decreased by more than 30%, which is a direct result of detecting cancers earlier through screening and improvements in treatment. That's a clear success story for screening.
Here's where it gets really interesting and is a major area of focus in the text. During the exact same 30-year period that we saw decreases in older adults, the incidence rates of CRC in men and women under 50 years old who don't have specific enhanced genetic risk or a strong family history have risen by 2% each year.
That's a substantial and sustained increase in a younger population that historically wasn't considered high risk. The consequence, as highlighted in the text, is that symptoms in this younger group are often initially dismissed or attributed to other causes like IBS or hemorrhoids.
Leading to delays in diagnosis.
Exactly, which means that when CRC is finally identified in younger adults, it's often at a more advanced stage of the disease.
And the direct result of being diagnosed at later stages, a corresponding increase in mortality rates from colorectal cancer is now clearly evident in this young adult population. This is a serious and growing problem.
This is the core puzzle the text presents. It explicitly states that no single distinguishing etiologic cause, molecular factor, or clinical characteristic accounts for this rising incidence in younger men and women compared to older adults. We know it's happening, the trend is undeniable, and it's having a real impact on mortality, but the underlying reasons are not yet clear from the sources, making it a critical area for research and clinical attention right now.
It's a major clinical mystery that needs solving. Let's move into the known etiology and risk factors for CRC, which are quite diverse, as outlined in the sources. The text lists factors like diet, hereditary syndromes, inflammatory bowel disease, Streptococcus bovis bacteremia, and tobacco use. We'll unpack several of these in detail.
Starting with diet, the sources provide strong evidence. The weight of epidemiologic evidence looking at patterns in large populations strongly implicates diet as a major causative factor. Specifically, diets high in animal fat and total calories are linked to increased risk.
The text connects this nicely to geographic variation. CRC rates largely don't follow genetic heritage. Rather, migrant groups tend to assume the CRC rates of their adopted countries.
Within a generation or two, yeah. Examples given include lower rates in groups like Mormons and Seventh-day Adventists, and the noted increase in CRC incidence in Japan as the population has adopted a more Western diet high in animal fat.
The sources discuss several hypotheses linking diet to CRC risk, although they note limitations for each. One is the animal fats hypothesis.
Right. The idea is that high intake of animal fats, particularly red and processed meats, can alter the gut microbiome. This leads to an increase in certain anaerobic bacteria like Fusobacterium nucleatum and Bacteroides fragilis, which are also found in higher abundance in CRC patients. These bacteria might convert normal bile acids into potentially carcinogenic compounds in the gut. High serum cholesterol is also mentioned as associated with increased risk.
Another hypothesis is the insulin resistance hypothesis. High calories, inactivity, obesity.
Exactly, leading to insulin resistance, which means increased circulating levels of insulin and insulin-like growth factor I, IGF-I. These are thought to stimulate the proliferation or rapid growth of cells in the intestinal lining, potentially increasing cancer risk.
Here's a point that might be surprising to many listeners. The fiber hypothesis. We heard for years that fiber was protective.
Yeah, but the text states that results from randomized trials and case-controlled studies failed to show a clear benefit for dietary fiber or diets high in fruits and vegetables in preventing the recurrence or development of CRC. While fiber is good for gut health overall, its direct role in preventing CRC development isn't as strongly supported by the evidence in this text as previously thought.
That definitely challenges some common beliefs. Let's move on to the significant area of hereditary factors and syndromes.
The text states that up to 25% of patients with CRC report a family history, suggesting an inherited predisposition. These inherited forms are generally divided into two main categories: the uncommon polyposis syndromes, with thousands of polyps, and the more common non-polyposis syndromes like Lynch syndrome.
Let's really understand polyposis coli, or familial adenomatous polyposis, FAP.
This is a rare condition, autosomal dominant, meaning one copy of the gene is enough. It's characterized by literally thousands of adenomatous polyps throughout the large bowel.
And the genetic basis is very specific here. It's associated with a deletion in the long arm of chromosome 5, which includes the APC gene.
Right, in both tumor cells and normal cells. The mechanism is critical. APC is a tumor suppressor gene. Loss of its function results in the absence of these suppressor proteins, leading to uncontrolled proliferation and polyp formation.
The text also describes variations like Gardner syndrome.
Yes, FAP plus other features like bony tumors, retinal spots, desmoid tumors, ampullary cancers, and Turcos syndrome, which is FAP plus malignant brain tumors.
What's the risk for patients with polyposis coli developing full-blown cancer?
Extremely high. Polyps generally appear by age 25. The text is very clear. Almost all patients under 40 will develop invasive CRC if the polyposis is not surgically treated. It's a fundamental defect in the colon's growth pattern.
Let's also briefly mention MYH-associated polyposis, or MAP.
Another rarer polyposis syndrome. Unlike FAP, it's autosomal recessive, needing mutations in both copies of the MUTYH gene.
Presentation can vary.
Yes, sometimes like FAP, sometimes early onset CRC without massive polyposis. Management guidelines are less clear, but generally recommend colonoscopic surveillance starting around age 25-30.
Now let's move to Lynch syndrome, historically called HNPCC, more common than FAP, also autosomal dominant.
The text outlines the diagnostic criteria, similar to the Amsterdam criteria. 3 or more relatives with CRC, 1 first degree, 1 diagnosed before 50, across at least 2 generations, helps identify families.
A key difference from FAP is Lynch syndrome often causes cancers in the proximal large bowel, the right side.
Exactly, and like MAP, the age of onset is typically younger, median age under 50, often 10-15 years earlier than sporadic CRC.
Here's an intriguing point the text makes about prognosis in Lynch syndrome, despite looking aggressive histologically.
Right, often poorly differentiated or mucinous. The proximal colon tumors in Lynch syndrome actually tend to have a better prognosis than sporadic tumors in similar age patients. Fascinating link between genetics, location, histology, and outcome.
The text also details the broad spectrum of other cancers that individuals with Lynch syndrome are at increased risk for: ovarian and endometrial in women.
Strong association there. Also increased risk for gastric, small bowel, genitourinary tract, pancreatic, and biliary tract cancers, often multiple primary cancers.
Given these risks, what does the text recommend for screening in Lynch syndrome families?
Annual or biennial colonoscopy starting at age 25. For women, intermittent pelvic ultrasound and endometrial biopsy are also mentioned for gynecological cancers, though the text notes this specific strategy isn't fully validated by outcome data yet.
What is the fundamental genetic basis for Lynch syndrome?
It's associated with germline mutations in several genes crucial for DNA mismatch repair. The text specifically mentions HMSH2 on chromosome 2 and HMLH1 on chromosome 3. These genes produce proteins that act like a spell checker for DNA during cell division.
So when these genes are mutated?
Errors accumulate in the DNA, particularly in areas called microsatellites. This leads to errors in DNA replication and a state of DNA instability, specifically referred to as microsatellite instability, or MSI. This instability results in abnormal cell growth patterns that can eventually lead to tumor development.
And how is Lynch syndrome diagnosed or suspected at the genetic level in someone who develops CRC?
The text describes molecular testing of the tumor tissue, analyzing the tumor for MSI or using immunohistochemistry to check for the absence of the mismatch repair proteins can indicate a deficiency. Finding high MSI or protein deficiency, especially with a family history, strongly suggests Lynch and warrants germline genetic testing on blood to confirm.
Helps identify affected individuals and test their families. Let's move to inflammatory bowel disease, IBD, as a risk factor.
Yes. Chronic inflammation in the large bowel significantly increases CRC risk. The text notes the incidence is higher in ulcerative colitis compared to Crohn's, though differentiation can be hard.
And the duration of IBD is critical. Risk small initially, then increases about 0.51% per year after 10 years.
That's right. Cancer may develop in 8-30% after 25 years. Higher risk in younger patients with pancolitis.
This presents a significant clinical challenge regarding surveillance. The text describes current strategies as unsatisfactory. Symptom overlap is a big issue.
Yes, distinguishing a flare-up from cancer symptoms like bloody diarrhea or cramping can be very difficult.
For patients with long history and ongoing issues, surgery is an option.
Yes, colectomy can significantly reduce cancer risk and eliminates the target organ.
However, the value of current surveillance methods, like routine colonoscopy with biopsies for less symptomatic individuals, is considered uncertain.
Exactly. The text highlights the controversy, citing lack of uniform criteria for dysplasia and absence of robust data showing it actually reduces lethal cancers. Raises questions about the trade-offs.
Underscores that not all common medical practices have definitively proven benefits. Let's briefly touch on a couple of other high-risk conditions mentioned.
Here's one of those surprising facts. Streptococcus bovis bacteremia. For unknown reasons, individuals with endocarditis or septicemia from this specific bacterium have a high incidence of occult colorectal tumors.
Wow, a bloodstream infection linked to colon cancer.
Yes, the text is clear. Finding this bacterium mandates a thorough GI workup. Fascinating link.
And tobacco use is also listed. Increased risk for adenomas, especially after long-term use.
Correct, particularly after 35 years of smoking, though the text doesn't propose a specific biological explanation for this association in the material provided.
Now, let's consolidate our understanding of how most colorectal cancers develop. This brings us to the pathogenesis, specifically the fundamental adenoma-carcinoma sequence.
The core model described is that the vast majority of colorectal cancers, regardless of the underlying cause, arise from pre-existing adenomatous polyps.
A polyp is just a visible protrusion. Pathologically, some are non-neoplastic, but others are adenomatous.
And the critical distinction, according to the text, is that only adenomas are clearly premalignant. However, and this is important perspective, only a minority of adenomas ever actually evolve into invasive cancer.
Adenomas are common, found in 30–50% of older adults, but less than 1% become malignant.
That's the key point. Most are asymptomatic too.
So how does this progression happen? The text describes it as a multi-step molecular process.
Yes, involving the accumulation of multiple genetic and molecular changes over time. The text mentions specific changes. Point mutations in the KRAS proto-oncogene.
Genes that can promote growth when mutated.
Right. Also changes like hypomethylation of DNA, which can activate genes inappropriately. And critically, loss of genetic material, allelic loss, affecting tumor suppressor genes like APC, DCC, and P53.
So it's a combination of activating growth promoters and losing growth suppressors.
Exactly. It's a series of hits disrupting normal control. The text does add a caveat that it's uncertain if these always occur in a defined order, but the model posits that cancer develops only in polyps where most, if not all, of these critical mutational events accumulate. Explains why most polyps don't become cancer.
Now let's discuss the clinical features of polyps and how they relate to the risk of malignancy. Probability depends on appearance, histology, and size.
Correct. Gross appearance. Pedunculated, stalked versus sessile, flat. Invasive cancers are more frequent in sessile polyps, especially those with a serrated pattern.
Histologically, adenomas can be tubular, villous, or tubulovillous. Villous adenomas have a higher risk.
Yes, more than 3 times the malignancy risk of tubular adenomas, and they are often sessile.
And size is a very strong predictor. This is key actionable information.
Absolutely. Likelihood of invasive cancer. Negligible, 2% if 1.5 centimeters. Intermediate, to 10% if 1.5, 2.5 centimeters. Substantial 10% if 2.5 centimeters. This size risk correlation is critical for management.
So what is the recommended management and surveillance after polyp detection?
Initial step, crucial. The entire large bowel should be visualized endoscopically if possible. Synchronous lesions are found in about 1/3 of cases. Can't just remove one and stop.
And follow-up is essential. Higher risk for another adenoma or cancer.
Yes, 30–50% chance of another adenoma, higher risk for CRC. So colonoscopy should be repeated periodically for surveillance.
Frequency. The text suggests polyps take 5 years to become significant.
Generally, yes. So colonoscopy usually not needed more frequently than every 3 years for most patients after polyp removal, but depends on the findings.
Let's return briefly to the management of polyposis syndromes, adding detail for FAP.
Primary treatment and prevention. Total colectomy once multiple polyps are detected.
Medical therapy. NSAIs can shrink polyps temporarily.
Yes, like Sulindac, celecoxib. But crucially, the text states they have not been shown to reduce cancer risk. Surgery remains primary.
And for offspring, 50% risk. Annual flexible sigmoidoscopy screening starting early.
Yes, starting in early teens until age 35. Proctosigmoidoscopy is sufficient initially because polyps are usually throughout. Fecal occult blood testing is inadequate.
And genetic testing can provide definitive diagnosis even before polyps develop.
Right. If the family's APC mutation is known, testing at-risk relatives' blood DNA is a powerful tool.
And just revisiting cancer surveillance in IBD one more time, the text re-emphasizes the controversy.
Still uncertainty due to lack of uniform dysplasia criteria and unproven benefit in reducing lethal cancers. A clinical dilemma.
All right, let's shift gears now to prevention and screening strategies for the general population. Segment 3. Prevention and screening strategies for colorectal cancer.
This is a critical area for public health impact. We'll start with primary prevention, or chemoprevention using meds or supplements to inhibit cancer.
The text highlights NSAIDs, particularly aspirin, as most effective. They suppress cell proliferation by inhibiting prostaglandins.
That's the theory. The benefits mentioned are significant. Regular aspirin use reduces risk of adenomas, carcinomas, and death from CRC. Also diminishes likelihood of more adenomas after removal. Effectiveness increases with duration and dose.
Vitamin D, emerging data linking adequate levels to reduced risk, looks promising.
It does. Its value as hemoprevention is under study.
In contrast, antioxidant vitamins like C, E, beta-carotene were found ineffective.
Yes, at reducing subsequent adenomas in trials. Counterintuitive for some, perhaps.
And estrogen replacement therapy in women is associated with reduced risk.
Associated, yes. Possible mechanisms involve bile acids or decreasing IGFI.
Moving from prevention to screening, the rationale is clear. Polyp removal prevents CRC, early detection improves cure rates.
Exactly. Especially important for those with a first-degree relative history, risk is higher.
The text reviews various screening strategies: digital rectal exam, stool testing, occult blood, DNA, imaging, barium enema, virtual colonography, and endoscopy, flex-sig colonoscopy. Let's look at the evidence.
Historically, the digital rectal exam. Limited value now because tumors are often higher up.
Correct. Proximal migration means fewer are within reach.
Fecal occult blood testing, FOBT. Major limitations, high false negatives due to intermittent bleeding.
Yes, up to 50% of documented cancers can have negative tests. Also, low positive predictive value. Most positive tests in asymptomatic people aren't cancer or even polyps.
Positive test requires colonoscopy follow-up. Costly if many false positives.
Right, justifiable only if proven to improve outcomes. And controlled trials did show a reduction in CRC mortality with annual stool guaiac screening.
But the text nuances, benefit emerged only after 13 years, was extremely expensive due to false positives, and likely came from polyp removal during follow-up colonoscopies.
Essentially acting as a trigger for preventative colonoscopy.
Fecal DNA testing. Look for mutations in stool. More effective than FOBT, but sensitivity 50% compared to colonoscopy.
Yes, which diminished enthusiasm.
Imaging studies. Barium enemas historical. Virtual CT colonography. Alternative to endoscopy. Propose as equivalent sensitivity, more available. But limitations. Requires same cathartic prep as colonoscopy. Major barrier. It's diagnostic, not therapeutic. Positive findings need later endoscopy. And appears less sensitive in general practice compared to endoscopy.
Given these limitations, recommendations shifted towards endoscopy.
Yes. Standard recommendations now. Either annual FOBT plus flex-sig every 5 years, or colonoscopy every 10 years, and starting age lowered to 45 due to the rise in younger adults.
Let's examine the evidence for flexible sigmoidoscopy. Powerful trial results.
Very powerful. 3 large randomized trials, 350,000 people, showed periodic, even single sigmoidoscopy reduced CRC development by 21% and mortality by 25% after a decade.
Significant impact from a less invasive test, and most participants didn't even get a full colonoscopy.
Right, less than 20% did. Its practicality is highlighted. Less prep, enema, less invasive can be done by non-specialists. Text quantifies efficiency. 650 screen to prevent 1 death compares well to mammography.
Benefit presumed from removing polyps in the distal colon, but intriguing that it works, leaving the proximal half unvisualized.
This leads into the ongoing colonoscopy versus flexible sigmoidoscopy debate. Is full colonoscopy more effective in reducing mortality? Ongoing European trials are looking at this.
Assumption is whole colon view is better, but text says colonoscopy less accurate for proximal colon. Technical issues, flat polyps.
That's reported, yes. And relevant to younger adults, most of their CRCs arise in the left colon, within reach of flex-sig.
So, while colonoscopy every 10 years is offered, and superior to barium enema, is it medically superior and economically equivalent to other effective strategies? Still being determined.
It's not a settled debate. This section really maps out the screening landscape, successes, and ongoing questions.
All right, let's move into segment 4. Clinical features, staging, and prognosis of colorectal cancer. How a patient presents often depends on tumor location.
That's right. In the right colon, cecum ascending, stool is liquid. Tumors can get large without obstruction.
So common symptom is chronic blood loss, leading to iron deficiency anemia, fatigue, palpitations.
Exactly. Ulceration causes slow, insidious bleeding, often occult, can become profoundly anemic. Even occult blood tests might be negative intermittently.
Critical takeaway. Unexplained iron deficiency anemia in an adult, except maybe premenopausal women, mandates a full, large bowel evaluation.
Absolutely. Rule out right-sided CRC.
Shifting to transverse and descending colon. Stool more formed, narrower lumen.
So tumors here are much more likely to cause obstructive symptoms. Cramping, changes in habits, obstruction, even perforation.
Radiographically characteristic apple core or napkin ring lesion.
Yes, annular, constricting. This appearance is always suspicious for malignancy.
Finally, rectosigmoid region, close to the end.
Symptoms often related to bleeding and elimination. Hematochezia, bright red blood. Tenesmus, incomplete evacuation feeling, narrowing stool caliber, anemia less frequent.
Clinical dilemma. Symptoms might suggest hemorrhoids, but any rectal bleeding or habit change needs investigation.
Demands a prompt digital rectal exam and proctosigmoidoscopy, cannot just assume hemorrhoids.
Understanding these location-specific symptoms is crucial. Once diagnosed, next step is staging. Let's discuss staging, prognostic factors, and patterns of spread.
Prognosis primarily related to 3 factors: depth of penetration, T, regional lymph node involvement, N, and distant metastases, M.
The AJCC-TNM classification. Stage 1.
Superficial tumor, no nodes. T12M0M0, 5-year survival, 90%. Excellent.
Stage 2.
Through muscularis or beyond, still no nodes, T34N0M0, 5-year survival, 70-85%. Good.
Stage 3.
Regional lymph node involvement, NET-N12M0. Prognosis drops significantly, 25-70%, 5-year survival depending on node burden, N1-13 nodes, N2 or 4 nodes.
Stage 4.
Distant metastasis, NET-NEN-M1, liver, lung, etc. 5-year survival, 5%. Crucial point. Unless obvious mets are present, definitive stage requires surgical resection and pathology. Can't know T and N for sure beforehand.
Most recurrences within 4 years, so 5-year survival is a good indicator of cure. Survival rates improve due to more thorough staging.
Yes, more thorough surgery and pathology leads to more accurate staging.
Lymph node nuance. Not just yes, no, but number involved. N1 versus N2 matters. And number examined is critical.
Absolutely. Minimum of 12 nodes should be examined for accurate staging. The more, the better. Impacts confidence in stage.
What other factors predict poorer prognosis beyond TNM?
Several listed, table 81 of 4. Tumor penetration into fat, poorly differentiated histology, perforation adherence to organs, risk of local recurrence, venous invasion.
Molecular markers too. High preoperative CEA level, 5 ngml, predicts recurrence.
Yes, regardless of stage. Also, mutation in the BRAF gene predicts higher metastatic risk. Conversely, microsatellite instability, MSI, indicates a more favorable outcome.
Right-sided location associated with poorer prognosis than left-sided. Likely molecular differences.
Correct. That's a key detail. Interestingly, prognosis is not influenced by the size of the primary lesion. Depth and spread are key.
Patterns of spread. How does it metastasize?
Primary routes, regional nodes or to the liver via portal vein circulation.
Liver is most common site.
Most frequent visceral site. Initial site in 13 recurrences, involved in 23 at death. Rarely spreads elsewhere, lungs, bone, brain, without prior liver spread.
Exception. Distal rectal tumors can spread via paravertebral venous plexus, bypassing liver, reaching lungs nodes first.
Exactly. Fascinating anatomical detail. Good news. Median survival after detecting distant mets has increased significantly, now 27-30 months with better therapy.
Pathologic stage remains the best predictor of outcome, supplemented by factors like CEA and lymphovascular invasion.
Really lays the foundation for deciding treatment.
Speaking of management, let's move to segment 5. Treatment and management of colorectal cancer. Goal is total resection.
Optimal treatment, yes. Total resection of tumor, margins, lymph nodes, cornerstone of cure.
Preoperative evaluation crucial. Check for mets.
Yes. Physical exam, liver function tests, CEA level, CT of chest, abdomen, pelvis. Also, pre-op colonoscopy of entire bowel if possible. Check for synchronous lesions.
What if mets are found before surgery?
Doesn't necessarily preclude surgery if needed for symptoms like bleeding obstruction, maybe less radical procedure. Surgery for asymptomatic metastatic patients is controversial.
During surgery, careful exam of abdomen, liver, pelvis needed.
Yes. Thorough intraoperative assessment.
After surgery, post-operative surveillance is critical.
Careful observation for 5 years. Semi-annual exams, blood tests, post-op colonoscopy if not done pre-op.
CEA monitoring. Some favor every 3 months.
Yes. Sensitive marker for recurrence. Circulating tumor DNA, ctDNA, is being studied as well.
Subsequent endoscopic surveillance needed. Higher risk for new cancer polyps.
Yes. Probably triennial colonoscopy, 3 to 5% chance of new CRC, 15% risk for adenomas, anastomotic recurrence rare with good margins. Periodic CT scans sometimes recommended, value uncertain.
Now, rectal cancer-specific treatment. Unique considerations due to pelvic location.
Big difference here. Radiation therapy to pelvis is standard for stage 3. Reduces high local recurrence risk, 20 to 25% after surgery alone.
Why is local recurrence so high? Pelvic anatomy.
Confined space limits resection, rich lymphatics facilitate spread, improved surgical technique, TME, reduces recurrence to 10%, but radiation helps further.
Radiation alone doesn't improve survival, though.
Not significantly. Needs to be combined.
Combined modality approach is key.
Exactly. Combining radiation with 5-FU-based chemo, preferably given before surgery, neoadjuvant, lowers local recurrence and improves overall survival. Better tolerated pre-op too. Contrast with colon cancer, where radiation isn't primary treatment.
Let's turn to systemic therapy, mostly for advanced metastatic disease. More effective now.
5-FU remains the backbone. Modest response alone, but enhanced with other agents. Hepatic artery infusion has limits.
Efficacy improved by folinic acid, Luke over an LV.
Oral capecitabine, similar.
Yes, LV enhances 5-FU binding. Capecitabine is an oral prodrug.
Key combination regimens revolutionize treatment. FOF, FEF.
Folinic acid, 5-FU, irinotecan, topoisomerase 1 inhibitor. Improves response survival. Main side effect, diarrhea. Given every 2 weeks usually.
Folinic acid, 5-FU. Oxaliplatin, platinum analog, also improves response survival. Main side effect, dose-dependent sensory neuropathy, also every 2 weeks.
Sulfolari and Ofalfox are equal in efficacy. Median survival now 2 years.
Yes, significant improvement for metastatic disease.
Beyond chemo, monoclonal antibodies used.
Yes, often with chemo. EGFR inhibitors like cetuximab, panitumumab, target EGFR protein, benefit some patients. Cetuximab might synergize with irinotecan.
Big limitation. Not effective if tumor has RAS or BRAF mutations. Need molecular testing.
Critical point. Doesn't work in 65% due to these mutations. Also appear less beneficial in right-sided tumors. Acne-like rash correlates with efficacy. Note, EGFR tyrosine kinase inhibitors don't work in CRC.
Another key antibody, avasizumab Avastin, targets VEGF anti-angiogenesis.
Right. Addition to chemo, like FOLFOX, significantly improves outcome. Side effects, hypertension, proteinuria, blood clots.
Immunotherapy, checkpoint inhibitors.
PD-1, PD-L1 inhibitors. More effective than chemo, but only in a specific subset, 15%, whose tumors are mismatch repair deficient, DMMR, or MSI high. Huge advance in personalized medicine based on tumor genetics.
Managing metastatic disease confined to the liver.
Carefully selected patients with solitaric or few liver mets might be candidates for partial liver resection. Offers potential for long-term survival, 25-30% 5-year rate.
Finally, adjuvant therapy after curative surgery.
Stage 3, colon cancer. Standard. 5-FULV for 6 months reduces recurrence 40%, improves survival 30%. Adding oxaliplatin, FOLFX, further reduces recurrence.
Duration debate, 3 versus 6 months of FOLFX.
Yes. 3 months might be enough for lower risk stage 3, T2-3N1, with less neurotoxicity. 6 months still recommended for higher risk, T4N2. Refining treatment. Notably, adding irinotecan, bevacizumab, or EGFR inhibitors has not worked adjuvantly for colon cancer, despite working in metastatic setting. An unanswered question why.
Stage 2 colon cancer. Adjuvant value less clear. Usually restricted to patients with poor biologic characteristics, perforation, T4, lymphovascular invasion.
And stage 3, rectal cancer. Pre- or post-op combined chemo plus radiation is standard adjuvant approach. Reduces recurrence, increases cure chance, pre-op, better tolerated.
That provides a comprehensive picture of CRC treatment.
Covers the spectrum from surgery to complex systemic therapies guided by molecular features.
Let's move briefly to segment 6. Cancers of the anus, distinct from CRC.
Yes, relatively uncommon, 1-2% of large bowel malignancies arise in the anal canal. Different histologies based on location relative to pectinate line, basally logogenic, proximally squamous distally. Prognosis similar when corrected for size nodes.
Key etiology is human papillomavirus, HPV, same virus as cervical cancer.
Exactly. Sexually transmitted, can lead to warts, condyloma, then precancerous changes, AIN, then squamous cell carcinoma.
Risk factors linked to HPV immune status.
Sure.
Homosexual males, people with AIDS. HPV vaccination is preventive.
Yes, vaccination appears to reduce eventual risk. Cancer is most common in middle age, more frequent in women. Symptoms: bleeding, pain, mass sensation, itching.
Now the treatment, a major shift highlighted in the text.
Huge shift. Historically, radical surgery, APR with permanent colostomy, was standard. Survival okay for node negative, poor for node positive.
Current standard is non-surgical, combined chemoradiation.
Yes. External beam radiation plus concomitant chemo, 5-FU and mitomycin C, results in complete tumor disappearance in 80%, especially smaller lesions. Recurrence, 10%.
So most patients cured without surgery or colostomy.
Around 70% can be. Dramatic improvement in cure rates and quality of life. Surgery now reserved for residual tumor after chemoradiation.
Recurrent disease treatment. Immunotherapy can help.
Yes, checkpoint immunotherapy, PD-1 inhibition, beneficial in some patients.
Anal cancer really shows how understanding etiology led to a better treatment paradigm.
One of the real success stories presented here.
Finally, Segment 7, Introduction to Liver Cancer Risk Factors from Chapter 82 start.
Liver cancer, significant global problem. 6th most common cancer, 4th leading cause of cancer death, leading cause of death in cirrhosis patients.
Mostly hepatocellular carcinoma, HCC, 85–90%, followed by cholangiocarcinoma.
Correct. Global burden increasing maybe 1 million cases here by 2025. HCC specifically, 850,000 cases here.
Geographic variation, highest in Asia-Africa due to HBV. Intermediate in European.
Yes. U.S. specifics, #1 in increased mortality over past 2 decades. 35,000 cases here. Strong male preponderance, 2.5.1. Incidence increases with age, peak 65-70, but younger in high HBV areas, 40-50.
Key risk factors. Text is clear. Cirrhosis is the main factor.
Underlies 80% of HCC worldwide, advanced scarring from chronic liver damage, any etiology.
Common causes of cirrhosis linked to HCC.
Highest annual risk, 3 to 8% urine cirrhotics from chronic HBV or HCV infection. Also alcohol abuse, metabolic syndrome.
Hemochromatosis, iron overload linked to HFE1 gene mutations.
Yes. Less common causes with 1–3% annual risk. NASH itself, alpha-1 antitrypsin deficiency, autoimmune hepatitis, Wilson's disease, cholestatic disorders.
Profound impact. 1% of population cirrhotic, 1/3 develop HCC.
Staggering statistic. Highlights importance of identifying and managing cirrhosis risk. The text mentions predictors among cirrhotics exist, but cuts off before listing them.
So core insight. Cirrhosis from almost any cause is the main driver. Viral hepatitis most potent trigger.
That sets the stage for understanding HCC risk.
That concludes our dive into the material provided on lower GI cancers and the introduction to liver cancer risk factors.
We've covered a significant amount of ground, from rare small bowel tumors to the complex landscape of CRC, success in anal cancer management, and the critical link between cirrhosis and liver cancer.
We've seen how disease patterns change, like the rising CRC incidence in young adults. We've explored genetic links and the molecular steps to cancer.
We examined screening evidence, benefits, limitations, and how treatments evolved, often guided by tumor characteristics.
What's truly fascinating is the dynamic nature, the constant evolution, ongoing debates like IBD surveillance, and the promise of targeted therapies and immunotherapy.
Mastering these topics really requires integrating knowledge across genetics, lifestyle, environment, microbiome, diagnostics, and therapeutics.
Here's a final provocative thought for you to consider. Given the evidence for lifestyle factors like diet, the risks from genetic syndromes like FAP and Lynch, and the emerging role of molecular testing, how should individuals and healthcare systems best navigate the balance between broad public health interventions and screening versus more targeted screening, prevention, and personalized treatment based on individual risk and tumor profiles?
A complex challenge indeed, optimizing resources and outcomes, a question shaping the future.
That wraps up our deep dive into this challenging but critically important area of oncology based on the material you shared.